the project and the significance of the problem, I want to start off with what perioperative fasting is and why this is important to anesthesia providers. Preoperative fasting is a practice that is in place to aid in the prevention of perioperative pulmonary aspiration. Patients are asked to withhold food and drink for a period of time, which is typically determined by a physician prior to their surgical procedure to ensure proper gastric emptying has occurred prior to the induction of anesthesia. In addition to the time that the patients are asked to fast, there can be any number of reasons that the perioperative fasting times would be prolonged. This can include poor clinical communication, which is clinical communication between staff members, misunderstanding of the guidelines by the patients, and surgical schedule delays. The current practice at a Midwestern 300-bed level 2 trauma center is for elective surgical patients to begin fasting at midnight the night before their scheduled procedures. Patients that require certain medications are instructed to take medications the morning of surgery with a sip of water. In 2017, the American Society of Anesthesiologists, or the ASA, revised their recommendations for preoperative fasting to reflect the following. Patients that have ingested a regular meal, which would include fried or fatty foods, a large meal would be 8 hours. A light meal or non-human milk, which is infant formula, is 6 hours. Breast milk is 4 hours, and clear liquids is 2 hours. Once this practice deficit was identified, I utilized a literature review to examine preoperative fasting protocols, prolonged fasting, and the benefits of preoperative carbohydrate loading to gather data supporting the development of the fasting protocol. My initial search included publications from 2012 to 2017. Once the project progressed, I did include publications from 2018 and 2019 in order to further support the project. Databases included CINAHL, PubMed, and ProQuest, and I included full text and English language publications. Some of the search terms that I included were preoperative fasting, prolonged fasting, carbohydrate loading, gastric emptying, clear liquids, and elective surgery. The exclusion criteria for my literature review was any publication that was non-full text, non-English language published, and studies that involved the pediatric patient population, as they were not going to be the focus of my project. When performing the literature review, I found that the lack of protocol was quite common and that several institutions are hesitant to adopt updated fasting guidelines. However, the absence of updated fasting protocols and the need for following most recent guidelines demonstrates that the period of pre- and post-operative fasting times can become very lengthy, showing the importance for change for clinical practice. Studies show that despite the current recommendations, average surgical fasting times can range anywhere from 12 and a half to 16 and a half hours prior to the induction of anesthesia. These long fasting times can be detrimental to a patient's nutrition status and additionally result in unsatisfactory experiences for the patients. Surgical stress worsens the catabolic state of metabolism, which leads to insulin resistance and can cause a delay in surgical recovery. The prolonged fasting can be related to several reasons, a few of which I had mentioned earlier. The biggest culprit was found to be the surgical schedule delays, which resulted in over 60% of the cases being delayed by greater than 60 minutes. Because of the effect of prolonged fasting times, the safety of shortened fasting times needed to be examined. It was found that decreasing preoperative fasting times and ingesting a carbohydrate-rich solution before surgery did not show any statistical significance related to an increase in risk for pulmonary aspiration, any change in gastric emptying, decreased patient outcomes, or an increased length in hospital stay. One of the biggest concerns with reducing preoperative fasting is that providers run the risk of not allowing a patient's stomach enough time to empty prior to the induction of anesthesia. Data shows that ingesting clear liquids up until 2 hours before surgical procedures results in less risk for aspiration for patients and no definite difference in stomach content pH or gastric volume when compared to patients exposed to more extended fasting periods. What about special patient populations? So studies have also been conducted to evaluate gastric emptying in patients who may have a delayed gastric emptying, such as elderly patients or obese patients. These studies have shown that in both populations, the at-risk patients exhibit no delay in gastric emptying when compared to patients who are younger or those who have a healthy BMI comparatively. It has also been shown that preoperative carbohydrate loading and reduced fasting results in improved gastric motility, as evidenced by a shortened time between the time of surgery and the time of the first bowel movement postoperatively. In regards to cost savings and the use of hospital resources, a study was conducted on patients undergoing open heart surgery for coronary artery bypass grafting. The patients were divided into a control group, which received no preoperative carbohydrate or intraop fatty acid infusion, and an experimental group that did receive preoperative carbohydrates in addition to fatty acid infusions intraoperatively. The groups who received the preoperative carbohydrate doses, as well as intraoperative fatty acid infusions, showed that only 32.5% of these patients required admission to the ICU for recovery postoperatively, compared to the control group who did not receive these pre-op carbohydrates, which resulted in 71.2% of these patients requiring the use of vasoactive medications and the admission to the ICU for recovery. The last concern that I addressed with my literature review was the length of hospitalization. The average length of hospitalization for patients receiving preoperative carbohydrate loading versus a standard fasting were similar or reduced. Patient populations utilizing a traditional fasting method versus reduced fasting with preoperative carbohydrate loading both showed an average hospitalization of 4 days. However, patients receiving preoperative carbohydrates reported less discomfort, less anxiety, and overall better postoperative outlook. The enhanced recovery after surgery protocols, which I will be discussing next, compared the length of hospitalization in patients undergoing colon resection procedures. The average hospital stay prior to the implementation of the reduced fasting protocols was 10 days. And with the use of the protocols, they saw this decrease to an average of a 2-day stay following the procedure. So enhanced recovery after surgery, or ERAS. The project implementation site that I used expressed a desire to incorporate ERAS into their patient care. So I just included a brief overview of what ERAS is before we move on. The first set of protocols for ERAS were developed in 2001 by surgeons in Northern Europe to optimize outcomes for surgical patients using evidence-based medicine. These protocols were based on concepts pioneered in the 1990s to standardize multimodal approaches to patient care in order to reduce the variability in outcomes for surgical patients. ERAS encourages the use of quality patient care to improve functional capacity, which allows patients to return to baseline function faster after their procedures. The primary goal of ERAS is to decrease the patient's physiologic response to surgical trauma by optimizing nutrition, functional status, and limiting preoperative fasting. There are several ERAS protocols that they focus on pre-op, intra-op, and post-operative care of these patients to improve this functional capacity for the surgical clientele. The studies that have shown that the use of ERAS can reduce complication and recovery time by 30 to 50%. For my project, I utilized the Iowa model of evidence-based practice. This was created as a framework to guide healthcare professionals and organizations to establish change and integrate scientific evidence-based literature into clinical practice. The Iowa model utilizes a multidisciplinary model that can be utilized by practitioners and administrative staff to help examine practices that will affect patient outcomes. The Iowa model uses a series of multiple feedback loops to inspire reflection and project success. The focus points of the Iowa model include the identification of a problem-focused trigger, stating the question or the purpose, forming a team, conducting a literature review, designing and piloting the practice change, integrating this change into practice, and disseminating the results. This will be the methodology and project design utilizing the Iowa model revised. So my project design, the setting for my DMP project was a large nonprofit Midwestern hospital. This hospital is a 300-bed level 2 trauma facility and the primary clinical site for the nurse anesthesia program. My sample included medical doctors of anesthesia, or MDAs, at the project implementation site. This consists of 7 full-time anesthesiologists who oversee surgical cases equally. The first step of the IO model is to determine a practice deficit at the target project implementation site. I began by discussing potential improvement areas with a CRNA advisor, as well as discussing areas of needed improvement with former students who were familiar with the clinical site and current practice. The lack of an established fasting protocol for elective surgical patients was identified as an area for needed improvement. It also showed the desire to improve practice to follow current guidelines as well as incorporate ERAS protocols in the clinical setting was also identified. The second step of the IO model revised is the statement of the question or the purpose of the project. The purpose of my project was to implement a preoperative fasting protocol per the American Society of Anesthesiologists guidelines in conjunction with recommendations from ERAS protocols for preoperative carbohydrate loading. The protocol aimed to improve patient satisfaction, patient outcomes, and decrease hospital costs related to lengthy hospital stays, as well as the use of additional treatments during the patient's stay. The third step of the IO model is assigning priority to the project. This step of the model is used to determine the interest in adopting the protocol into clinical practice at the target implementation site and ensuring the project adds value to both the organization and the patient population. The priority was determined by meeting with the current anesthesia program director and a member of the anesthesiologist group to evaluate this interest. It was determined at that time that the lack of an established protocol supported the development of the proposed protocol. This fourth step of the Iowa model is to form a team. The Iowa model utilizes a team-based approach to strategically support the implementation process of the project. So my implementation team was myself as the project leader, Dr. Yates as my project chair, Dr. Dana Flatley's the clinical expert, and Dr. Nicholas Saras, who is an MDA at the targeted implementation site as a secondary clinical expert. Step 5 is to assemble and appraise the body of evidence. This step of the IO model guides the user to gather and review literature to support the project, which is ensuring that the project is built on strong data. A review of the literature pertaining to preoperative fasting and carbohydrate loading was conducted. Upon review, strong levels of evidence in literature were identified, which supported the use of preoperative fasting protocols and carbohydrate loading in the elective surgical patient. Step 6 of the IO model is there sufficient evidence? Reviewing the literature identified that there are substantial increases in preoperative fasting times due to several factors, including poor clinical communication, lack of understanding by the patient, and delays in surgical schedules. The literature also showed that decreased fasting times and ingestion of carbohydrate-rich solutions did not contribute to higher risks for pulmonary aspiration, operative or post-operative complications, delays in gastric emptying, or lengthy hospitalizations. Based on the gathered evidence, the project team determined it was acceptable to progress with the change project. The 7th step is to design and pilot a process change. I evaluated ERAS protocols for preoperative fasting to gather data on patient populations, comorbidities, anesthesia delivery, and carbohydrate solutions. With the gathered information, I developed a survey for the MDAs at the target implementation site to evaluate their familiarity with the current ASA guidelines, as well as to include any feedback that they may have to develop a site-specific protocol. On this slide, this is the survey that was distributed to the MDAs. So the first question is just asking if they are familiar with the current recommendations, if the consumption of preoperative beverages before surgery would change their anesthetic plan, if the volume of these liquids consumed would alter their choice in anesthetic plan. And then the last 2 questions allowed them to provide some feedback for patient populations that they either would or wouldn't include into the protocol, and if they had any concerns using preoperative carbohydrate loading in the elective surgical patients. Step 8 is the change appropriate for adoption into practice. So utilizing this survey, this provided me with a tool to evaluate their preferences as well as a feedback to use for implementation of the protocol. I used this feedback and the responses to help kind of develop this site-specific protocol moving forward. Step 9 is integrating and sustaining change. The Iowa model heavily focuses on sustainability of project development and implementation. Important factors that go into sustaining and integrating change are team engagement, environmental culture at the implementation site, and the availability of resources. These are all crucial to creating a sustainable project. Step 10 of the Iowa model is disseminating the results, which we are doing here today at Celebration of Scholarship, and then later on at Clinical Case Conference. So the last section here, this is data collection, project results, limitations, and future recommendations for the project. I received official IRB approval from Millikan University on March 4th of this year. Once approved, the survey was distributed to MDAs via email with an invitation to participate in the survey. The survey assessed the familiarity with the ASA's guidelines, if the carbohydrate loading would change their practice, and if they had preferences for use in certain patient populations, and allowed them to provide feedback. The MDs had 2 options for submission of the surveys, both allowing the physicians to submit their responses anonymously. In total, 7 surveys were distributed via email to their preferred email addresses as provided by the anesthesia department. 3 surveys were completed and returned to me, resulting in a 42% participation rate. This is just a little graph describing the results. So 100% of the survey respondents indicated that they were familiar with the current recommendations for preoperative fasting. 100% of them also said that consumption of preoperative carbohydrate-rich beverages would not change their anesthetic plan. Oh, that should say no, but it says yes. Anyways, the volume of clear liquids consumed, would that alter their choice in anesthetic plan? That was also 100% no. And then the last 2 questions, which allowed them to provide some feedback. 2 of the providers provided feedback about concerns regarding the preoperative carbohydrate loading. One said that the fasting period should be increased to 4 hours for patients who are diabetic. The other stated that there were no concerns as long as the carbohydrate ingested was a complex carb. The last question of the patient populations that should be excluded from the participation in the protocol, I had 1 respondent for that, and it was just that they would exclude the diabetic patient that did not meet a 4-hour fasting period. Unfortunately, I was unable to complete the development and implementation portion of my project in full due to some extenuating circumstances. Shortly after distribution of the survey and data collection, RNAi students were removed from clinical sites due to the COVID-19 pandemic. At that time, the project implementation site was granting campus access to patients and essential staff only in an effort to minimize the transmission and exposure of the virus, and placed all elective surgical cases on hold at this time. Due to limited access to the clinical implementation site and a significant decrease in elective surgeries, all future meetings regarding protocol development and implementation were temporarily suspended. Unfortunately, that temporary suspension has gone on a little longer than we were all hoping for. Despite this, I'm going to discuss what would have been occurring with the development and implementation of the project had I been able to move forward. In regards to the protocol, to determine the patient inclusion criteria based on recommendations from the MDA survey results, determine the appropriate fasting times for special populations, if any. This would include the diabetic patients, increasing their fasting time to 4 hours. Develop easily comprehensible education materials to be distributed to the patients. These would be utilized preoperatively and include appropriate carbohydrate solution products and the amounts to ingest prior to surgery. The ingestion of carbohydrate-rich solution should be completed the night before surgery, as well as the morning, at least 2 hours prior to the arrival at the hospital. Determine the appropriate surgical patient population and seek buy-in from surgeons. Preoperative fasting protocols can be utilized in a number of patient populations: gynecological surgeries, gastrointestinal, and obstetrics. So selecting one target population and evaluating its success could help determine if this was something that the institution felt that they would find appropriate for other populations as well to roll out as an institution-wide protocol. Make the protocol available to staff on the hospital's electronic database. This is an important step that is suggested by the Iowa model. Ensuring that resources are readily available is crucial to the sustainability. Lastly, establishing educational opportunities for staff to familiarize with the protocol prior to rollout. This would include MDAs, CRNAs, and perioperative nursing staff. A few of the limitations to my study were the small MDA sample size, small survey participation, and the limited ability for in-person communication with team members. Even though I was unable to complete the development within the time frame of the project, I feel this project is significant to advancing patient care at the target implementation site, and I would recommend that a protocol still be developed in the future. My recommendations moving forward would be to reestablish the views of the MDAs and their attitudes towards protocol implementation in an attempt to gain further feedback and a higher percentage of MDA participation. Utilizing the recommendations presented within this project and the survey responses in conjunction with protocols from a health system partner and ERAS protocols to develop a site-specific protocol for patients deemed appropriate for participation. Lastly, there has been an increase in interest regarding the use of ultrasound scans to evaluate patients' gastric content prior to the surgery, and I feel this could be a great tool in addition to the fasting protocol. My last recommendation would be for the implementation site to determine feasibility of utilizing ultrasound to assess the gastric content prior to future elective surgeries, which could help allow for better flow of the surgery schedule and assist in decreasing delays. And that is all.
Excellent work, Kaitlyn. Do we have any questions from our audience for Kaitlyn for today?
I just want to say good job, Kaitlyn. That was so good.
Thanks.
Yeah, good job, Kate.
I just have one question. Kaitlyn, good job. My question was to do with the enhanced recovery. I know we were studying this a little bit last semester, and I read something about this, and I was curious if you came across any research about how this affected like postoperative insulin resistance, because I know you mentioned the diabetics, and I remember reading something about it having a beneficial thing for the stress that induces peripheral insulin resistance. So did your research find anything about that being like a potential outcome to be measured with this?
It did. They've showed that ERAS protocols and decreasing the perioperative or like the preoperative fasting can assist in helping with insulin resistance postoperatively. For patients that are diabetic, they really recommend that further research be done for those patients, especially if you're going to include them in these protocols. So I think that moving forward, if they were going to utilize ERAS for the diabetic patients, those patients really have to be kind of screened well before being included to ensure that there weren't going to be any postoperative complications.
Cool. Thank you. Good job, Kaitlyn.
Thank you.
Nice
Congratulations,
job,
Kaitlyn.
Good job, Kaitlyn.
Happy for you.
Congratulations, Kaitlyn.
Thanks.
I was just going to make a comment really quick, Kaitlyn. I think I had told you like a year ago that my son, with all my son's surgeries in large metropolitan centers, they only kept him NPO 4 hours before all of his procedures and liquids, even like maybe 6 to 8 hours before the surgery. So I just think that, you know, we're kind of behind in the times and we need to move forward with it.
Yeah, I remember we had talked about that. Yeah, I think that that's partial. I really enjoyed this project, and it's just kind of interesting to see that how many institutions still are hesitant to adopt these fasting protocols when, you know, there's so much research out there that shows how beneficial it is to decrease these fasting times for patient populations.
Any other questions or comments for Kaitlyn? If not, we will adjourn this session, and we will be back at 11:45, I believe, for our next speaker. So very good.
Thanks, Kaitlyn.
Thanks, everybody.